In my last video, I talked about what to do if someone's immediately suicidal. If you're a therapist and your patient is high risk, what to do then. In this video, it's more when they get back from the 72-hour hold or if they are medium risk. So aside from just reflective listening and hearing them out and being your normal therapist self, you are going to want to have a safety plan. Not a no suicide contract. No. All that communicates is that if they die by suicide, that you want to make sure that you're not liable. Don't do that. Please don't do that. There's no evidence supporting that. If you were taught that, you were taught wrong, and I'm sorry you were taught wrong. Please do a safety plan instead. So, a safety plan, let's talk about what that is. First part of it, you want your client to write down warning signs that they may not be safe. You want a section where, okay, these are the things that let me know that I am out of control. Okay, maybe second portion, this is just a template by the way, maybe reasons to live. Here's some things to kind of why I shouldn't do this. You want a section on coping strategies. What helps them? What are their go-to strategies that are effective? What can they do to de-escalate their emotions in that moment? Another section might be people that they can be around, that they can open up to and say, hey, I need to be around someone right now. I'm at that point again. Maybe they've told them, I'm going through a hard time, I've been suicidal, I need to be around people. Maybe there's also other social situations where they can be around people in general, but maybe might also get to the point where they're around someone that can keep an eye on them. That's an important thing. So having them reach out to someone, maybe social situations, then having them reach out to someone, say, hey, this is where I'm at. I need to be around someone. I need support. Then numbers to call, crisis agencies that can help. This might be like suicide hotlines. Things to do that make the environment safe. More than 50% of suicides are by firearms. So if your client has firearms, which many people do, you're going to want to talk to them about, yeah, right now it's maybe not a good time to trust yourself. Let's have someone take care of these things for you. We don't want you to have access to this. If you have a good, strong therapeutic relationship with them, use that to make this argument. Because they're gonna, if all it takes is a few seconds of an emotion taking over, a few seconds of depersonalization and access to means. That's all it takes. So please have a conversation with them about giving their guns to someone in the meantime. Maybe as well, sharps. Depends on the individual. You're going to want these means to be restricted. So please have that conversation. This is what a safety plan looks like. You want this written out. You want a hard copy. You can have a copy, but you want your patient to have this so they can go through this to know, oh, looks like I'm getting to that point. What do I do next? You're not going to want to rely on their memory. You want this to be something that they can see, that they can go through, that they have access to. That can be very helpful. Then long term, shift your therapy to treat the depression. So if there's suicidality, let's say you're working on anxiety, you want to shift over for the depression. What's really interesting is there's some therapies that work entirely different from one another that have been shown to reduce suicidality. So let's take EMDR. EMDR reduces depression and can reduce suicidality. Cognitive behavioral therapy. So you have something that works through memory reconsolidation, bottom-up processing. Over here you have top-down processing, and more working through extinction. Or you can go an entirely different route and do attachment-based family therapy, getting a secure attachment. All of these have studies showing that it reduces depression and suicidality. So it doesn't necessarily, there's not like one approach that is like the one you have to do. You just want it targeted for the depression. So that needs to be long-term treatment. If you are treating someone and they have suicidal ideation, look in the DSM-5-TR, the new updated version. There are now sections about suicide and suicidality and risk factors for each specific diagnosis. You're going to want to look at this to know risk, essentially, but also that might not be enough because there's some things that aren't in there yet. For example, let's say there is a 13-year-old female who has ADHD, and the ADHD is untreated. They are 5 times more likely to die by suicide. I don't believe that is in the DSM-5-TR. So you're going to want to know what the risk is, and it's very easy if you have the DSM-5-TR to go to their diagnosis and look that up. There is a lot of good information there. So that's, I suppose, a plug. I never thought I'd give a plug for this, but yeah, I'm very happy that the DSM-5-TR has that. If you have one, you can go check that out. And hopefully that will help you conceptualize where things are for your patient. I hope this has been helpful. If you have any questions, let me know. If you are interested in CEUs for suicide and suicide prevention, let me know. I don't have CEUs available in all states, but I do put on workshops. So thank you for your time, and that's it for this video. Thanks.